I'm Dr. Allan Perel, and this is Conversations in Medicine, a program dedicated to bringing the most cutting-edge medical topics to the Staten Island and tri-state community. Tonight's topic is ear, nose, and throat. And you say, wow, those are three organs. Yep, we have an ear, we have a nose, we have a throat. But we put them together into a very long word called otolaryngology. And I have a wonderful specialist here from Richmond University Medical Center who's going to help us divide this up in this era of what we're looking for, and the idea of what pathology or what abnormalities occur with people's ears, nose, and throats. And my guest is Dr. Christopher Lisi. Welcome. Dr. Lisi is the Chief of Ear, Nose, and Throat at Richmond University Medical Center, but also the head of head and neck surgery. So if you think about the head has a lot of different parts to it. And why is that so important? Because there are different things that could happen. Anything from the thyroid, which is in your neck, to a tumor in your scalp, on your face. These are the kind of things that ear, nose, and throat specialists and head and neck specialists take care of. So we're going to jump right in with Dr. Lisi, and thank you so much for being here. And we even brought all his models here. Sometimes we have guests who I say, please bring a model. Dr. Lisi, this is the second time you're here, and you were a wonderful guest before a couple of years ago, and the models really have had more comments about your models than I've had about a lot of other things. So welcome. So let's just get back to the beginning of this and say, what's an ear, nose, and throat doctor?
Sure, and thanks again, Dr. Perel, for having me a second time on the show. I hope we could really help educate everyone, all of our viewers. Ear, nose, and throat doctor, like you said, an otolaryngologist, is a specialist in basically every aspect of the head and neck, from the neck up, excluding things like the brain, which is for neurologists and neurosurgeons, neurologists such as yourself, and the eyes, and excluding the eyes and excluding the teeth. But everything else is the territory of an ear, nose, and throat surgeon, which is a medical and surgical specialty. And that really includes a second kind of specialty as well, known as head and neck surgery, which is combined as ear, nose, and throat, head and neck surgery. And the head and neck surgery part of things actually more specifically refers to taking care of tumors of the head and neck, again, from the neck up, whether they're benign tumors or cancerous tumors.
So tell me, what kind of training does someone have to become an ear, nose, and throat doctor?
Well,
surgeon.
Yeah, I mean, it's a long path. It really is, and that's true for any surgical specialty, especially for ear, nose, and throat. I mean, it's a long path. You have to commit to it. You have to know you want to do something like that. And after your 4 years of college, of course, you got 4 years of medical school. And after your 4 years of medical school, you have to match to a very competitive residency. Ear, nose, and throat is very selective. You have to have high test scores, high marks in medical school, and then it's an additional 5 years minimum of training in this specialty beyond medical school. And you can go on to specialize in other fields that are 1 to 2 year fellowships beyond the residency.
So let's talk about in this year of the pandemic and COVID-19. Interestingly enough, I saw a statistic recently that ear, nose, and throat doctors, sad to say, were some of the most early people who were affected by this as physicians.
Yeah.
And in a sense, and it made sense after someone described it to me, dentists, ear, nose, and throat specialists, because you're looking in people's mouths and their noses, and that's where COVID exists. So tell us a little bit about your experience with COVID, and then we're going to also talk about one of the major side effects, or one of the major symptoms is a better word, that invariably almost every patient will describe is lack of sense of smell and subsequent lack of sense of taste. So tell us how COVID affected you guys.
Yeah, it was a big impact upon the specialty early on, especially in the height of the pandemic. Even before it arrived to the United States, you're hearing reports about ear, nose, and throat doctors and other related specialties about really being impacted in places like Wuhan, China, and in Italy. In fact, some of the ear, nose, and throat specialists, and even anesthesiologists, because they were doing lots of the intubations, putting breathing tubes into very sick COVID patients' throats put them on ventilators, being exposed to very high loads of virus in breathing, coughing, and respiratory secretions. And as an ear, nose, and throat doctor, I mean, your job is to look in people's noses and their throats. So it's a very high risk to be exposed, especially when we knew nothing about the virus, how it was transmitted, how deadly it could potentially be. To cite an example, there in China there was a big ear, nose, and throat surgery, actually what we call a transsphenoidal surgery, a brain tumor surgery being done through the nose with a combined team of neurologists and ear, nose, and throat doctors doing an endoscopic surgery through the nose and up to the brain. That patient, they didn't know it at the time, had COVID and exposed a lot of members of the operating room and of the surgical team to COVID. And actually, that was a case report in the literature, and a lot of people actually became sick from that exposure. And that was published, and we learned lots from that, and similar things happened in Italy as well.
So let's talk about decreased sense of smell with COVID. Most patients will get better, and the neurology behind this is interesting because initially we thought that the COVID virus actually goes into the nerves of the nose, of the olfactory, is the fancy medical word for the sense of smell. Turned out not to be the case. It goes to the supporting structures around it.
Sure.
And almost all of your taste is really through smell.
That's
so people lost the sense of taste and smell, so they usually go together. So tell us a little bit. I know you have the model. I know you wanted to talk a little bit about this. Tell us what happens when someone has a COVID infection and why they lose their sense of smell.
Sure, I can point it out on the model, and you're absolutely right. People don't realize this. The sense of taste is almost completely reliant upon the sense of smell. If you do not have a good or keen sense of smell, your taste is going to be diminished, invariably, definitely. And that's really because you're right. The COVID virus and the COVID virus really goes up into the high portion of the nasal passages as it's inhaled through the nose. And at the high portions of the nasal passage, just below the brain, are the olfactory nerves or the smell nerves, and they enter, through what we call the base of the skull from the brain into the top part of the nasal cavity. And as you were referencing, the virus replicates in the tissues surrounding the nerves high up in the nasal cavity, causes, basically the key word here is inflammation. It basically causes inflammation, which causes damage to the nerves or the surrounding structures of the nerves, which knocks out temporarily, thankfully for the most part, knocks out the sense of smell on a lot of people that have suffered from COVID.
So tell me, what's the timetable of when someone comes to you or to me and says that they've had COVID a few months ago, especially with the second or third wave of COVID, and they describe their decreased sense of smell? A few patients, I actually had an example of someone who worked in the spice industry, and they were very anxious. Of course, and again, just everybody themselves wants to smell and eat and enjoy things. So the idea of losing that sense was so important. And this man was just, his livelihood was on the line because of it. What usually happens? You said people usually get better. What time frame do people get better?
Yeah, so I think that a lot of there's still an ongoing area of research for sure, and it's a very interesting topic which has been researched before COVID, but now there's so much more interest in it. The timeline of smell loss can happen very early in the disease, so within a couple of days of contracting COVID. In some instances, it's the first symptom. So you can lose sense of smell, immediately after developing or before developing symptoms within the first few days. Most people's symptoms seem to go away after the virus stops replicating in their body, or after it's past the peak replication, so 7 to 10 days. A lot of people seem to get their sense of smell back within that 2-week period of time. Whether it's complete or not is a different story, but most of the smell comes back in that time. However, there are people who certainly linger and take much, much longer to recover their sense of smell, and I see a lot of those patients in my office.
So we're going to do this almost like rapid fire, because there's so many different parts of the head and nose, ear, all the things that we say. So just maybe even to go a little bit further, we talked about with COVID, but if somebody has a decreased sense of smell, and sometimes they come to me. I'm a neurologist, and we see this with some neurodegenerative diseases like Parkinson's disease and Alzheimer's disease. There's some literature that it might be one of the first symptoms that we have. But a vast majority, it's not. And a vast majority of patients, it's something wrong, something in the nose that's blocking the small particles from getting up to being perceived.
Yes, definitely.
So tell us, if someone has a problem with sense of smell, and basically you said if someone has a problem with sense of taste, which is almost invariably from sense of smell, would they go to an ear, nose, and throat doctor?
I think that's a very good place to start. Most, like 90% probably, of decreased sense of smell or trouble with smelling is due to nasal blockage, some form of obstruction in your nose, whether you have swollen tissues in the nose from allergies, swollen tissues from sinus infection, or nasal polyps. Nasal polyps are common, and they block the olfactory area, the area of that needs to be open for the sense of smell, and those things can be taken care of. That's the bread and butter of an ENT doctor. We take care of those things like chronic sinus infections and nasal polyps, and quite often these days with minimally invasive office procedures or all sorts of new medicines that can be delivered through the nose to help alleviate obstruction that can give people a sense of smell back. I would say it's never normal to have a decreased sense of smell, and it could often be very readily fixed and helped.
Let's go into sinuses. Everybody loves to talk about their sinuses. This time of year, there's allergies. Everybody's got a runny nose. They have a little pressure in their head. You know, interesting, as a neurologist, so many of my migraineurs think they've got sinus problems, but they really don't. You don't get episodic headaches with nausea and light sensitivity every 2 or 3 weeks, and from your sinus. It just doesn't happen a whole year. So tell us about the sinuses and where are they? And I don't know if you have any of your diagrams with it, but just the idea of everyone talks about sinuses. Where are they and what do they do for us?
Yeah, I mean, it's a great question. The sinuses are actually connected but separate parts of your nasal passages. They are the parts of the nasal passages below the eyes, above the eyes, between the eyes, and then there's a sinus all the way back in the back of the sinuses or in the back of the nose toward the brain. And on this side profile of the ear, nose, and throat, you have your sinus cavity here, you have a sinus here, you have a sinus above the eyes and in the forehead, and these are hollow air passages. They're supposed to be there to humidify and warm air and that type of thing. We don't know why evolution created them, but they're there, and they get inflamed and they cause sinus infections, or they can contribute. They can get infected, which is a sinus infection. And a lot of people suffer from this. And you know, if you get a cold or something like that, or a sinus infection, it lasts a week. Okay, no problem. Sometimes that's viral and it can go away on its own. Sometimes if it lasts longer than a week, you can get a course of antibiotics or sometimes steroids prescribed by an urgent care or a primary doctor or a pediatrician. But anytime some symptoms like that, like runny nose with thick discharge coming out of the nose, pain or pressure specifically in the face, that's worse when bending over, and just nasal obstruction, nasal blockage, it's a good time to see an ear, nose, and throat doctor.
In my family, we make a very big deal about the color of the discharge. The yellow, the green, and people come into my office and I don't want to hear about the color of the discharge. That's why I became a neurologist. So tell us, does it make a difference what color it is?
So I had a patient the other day who brought me his used tissues from the last 3 days, which, I know what it looks like, but it's interesting to see how people interpret their disease processes. Right? So the color doesn't matter that much. Although classically clear, watery drainage with itchy nose is more allergies. Thicker drainage that you may feel going down your throat that just is sticky, and the color doesn't matter so much, like you said, but that can be more of a sinus infection type scenario. But really the best way to know is to look in the nose, and we do this in the office with small endoscopes.
They put a small scope into someone's nose?
Yep. I do this right in my office. It's extremely well tolerated, and it's the real way to determine if there's an actual sinus infection going on. It's done under just a little topical anesthesia, a little spray in the nose, and while the patient is awake, and we do this in adults, children, just go right into the nose with a tiny camera, high-def camera, and able to see the openings of the sinuses and see if there's sinus infection or not.
How interesting.
Yeah, it's extremely accurate diagnostically.
Oh, that's super. And when people have polyps or little cysts in their sinuses, do they need surgery for them?
Yeah, sometimes. A lot of times, like I think you're referring to people that have MRIs of their brain or MRIs of their sinuses for headaches or other things, and they see a small cyst in the sinus or something like that. A cyst may or may not be something that's causing symptoms. In fact, a lot of people have these cysts in their sinuses. Just like you may have a small cyst in your throat, a small cyst under your tongue, something like that, that don't actually cause any symptoms. And they just arise from the lining of the sinuses or the nose. If the sinuses, though, are blocked by the cysts, they can get backed up with mucus and you can get sinus infections. Polyps are a different story because they tend to block the nasal passages and prevent breathing, and they block the drainage pathways of the sinuses and cause pus buildup and mucus buildup, which will cause sinus infections.
So we're going to jump ahead now. I'm going to go to throat. And you told me something before we came on the air that really fascinated me. I never thought of an ear, nose, and throat specialist as someone who really takes care of the thyroid. And we have a high incidence, as you mentioned, of thyroid cancer on Staten Island and in New York. And the idea that who would you send someone who has a large thyroid? And maybe you could tell us a little bit about thyroid disease with regard to a mass, a goiter, a nodule I mean, we see so much of that. And when do they need to come to someone like yourself?
Yeah, I take care of a lot of thyroid patients. I do several thyroid surgeries a month, and we have a busy thyroid practice, actually. And there is a high incidence of thyroid cancer on Staten Island, and this has been discovered recently, much more so than the other boroughs in New York City. We're not quite sure why, if we've just found more here by chance, or there is something that's contributing to it. But either way, I work hand in hand with endocrinologists, which are the medical specialty that takes care of thyroid hormone disorders, or the thyroid from a medical perspective. And I focus on operating on the thyroid when that's needed, either for an enlarged thyroid or nodules in the thyroid, or to make a diagnosis if there is thyroid cancer, or to remove the entirety of the thyroid if there is definite thyroid cancer. Interestingly, to answer your question, thyroid surgeries decades ago were more handled by general surgeons, and over the course of the last 20, 25 years or so, it's really shifted to ear, nose, and throat surgeons and head and neck surgeons. So we are expert neck surgeons, and the thyroid is something we take care of regularly.
Okay, so let's go inside the throat now. There's a lot of things, and your voice box is there, your larynx is there.
Yep.
And as a neurologist, we have people with this entity called dysphonia, where they have pressured speech because their voice box or their larynx doesn't relax enough,
Right.
the vocal cords basically. And sometimes you can get it too relaxed or not. Tell us a little bit about voice and throat issues that patients
Yeah,
would
you
have.
bring up an interesting topic. I don't think people think of it this way, but the throat and the larynx, or the voice box, is just like any other part of the body. It moves, it's dynamic, and it's controlled by muscles and nerves. So it's not something. Your swallowing is controlled by muscles. Your voice is controlled by the contraction and movement of muscles. And there's these complex system of nerves that come down from the brain into the neck and control all these muscles. So any issue with the brain, any issue with these nerves, or issues with the muscles can affect, of course, speech, swallowing, the voice. And dysphonia, or hoarseness, or the inability to produce a normal voice, can certainly be a neurological issue. And I see lots of those patients in my practice. And a lot of those patients have other things that aren't neurological. They could have an obstructive tumor in their throat. They could have a vocal cord cyst or a vocal cord polyp that's causing a hoarse voice or dysphonia. Or you can have like a neurological or degenerative disease, maybe like Lou Gehrig's disease, ALS, where you could really lose your function of swallowing and have a very, very weak voice.
So let's go through that again. So when would you go to an ear, nose, and throat doctor if you're hoarse? And there are people who are hoarse, and again, a lot of people have smoked in their years or been in polluted areas. The idea that some people think it's sort of natural to have that husky or that voice that we're trying to mimic. Tell us a little bit, when would you have this checked out?
Yeah, I think any swallowing or voice disorder needs a proper examination of the throat and the larynx. And I think at some point along the disease course, or the diagnosis of that, especially if it's not getting better initially, an ear, nose, and throat doctor should take a look in there. Again, it's done easily in the office with a small endoscope which goes in the nose, and we can look at the voice box to make sure there is nothing down there that we can see that's causing the issue. Like you said, a lot of patients that have these voice or swallowing disorders will come to a neurologist first, or they'll go to their primary doctor, and that is also a great place to start. I think that somewhere along the course of diagnosis and treatment, it's good to see an ear, nose, and throat doctor to properly examine.
So don't let that pass. If someone has this gravelly voice they've had for a couple of years, and it's getting weaker and worse and more raspy, it's really important, because you could have a tumor there, or you could just have a polyp or something that's benign that could be taken care of.
And specifically the gravelly voice, any hoarseness or any voice change that's lasted over 2 weeks or 3 weeks should be evaluated by an ear, nose, and throat doctor. You can absolutely develop a tumor, especially if the patient is a smoker or drinker. Higher risk for a throat tumor or cancer, that should be evaluated.
Tell us about the tonsils. So the tonsils, in medical school, it was always interesting. Over the many years since I graduated, tonsils went from being something that everybody had it taken out to now, and then an era that nobody had it taken out, and then an era that some people get it taken out. So, and I know you do pediatrics also.
Yes, absolutely.
So tell us a little bit about the pediatric portion, and that always, to me, sounds more like tonsils and adenoids, but tell us a little bit about it.
Right, so what's great about my practice is I'm a general ENT, so I see pediatric and adult patients, and we have another partner in the practice who just joined as well, Dr. Trosman, who also sees pediatric and adult patients. And tonsil problems, tonsillitis, enlarged tonsils, sleep apnea are big problems in the pediatric population. Enlarged tonsils can block the breathing at night. Enlarged adenoids, which are in the back of the nose, can cause nasal obstruction and discharge from the nose. And they, there's definitely a period decades ago where it was very, very common to have the tonsils out for children. It's still common. It's still one of the most common pediatric surgeries done in the United States. But we're way more careful on who we do it on and our patient selection. There are two reasons to take out the tonsils. One, for recurrent infections, constant sore throats that require antibiotics. And two, sleep apnea, or heavy snoring with pauses in breathing and decreased oxygen levels, which is somewhat common in kids. Having the tonsils and adenoids out is oftentimes curative.
Tell us about in adults. Sleep apnea is so common, and so many of our viewers have been told they have sleep apnea, they're snoring. And snoring itself is not enough for the diagnosis.
That's right.
And you don't have to be overweight to have sleep apnea.
Nope.
Are there any procedures? Again, people sometimes don't want to wear the masks their whole life. And we keep on seeing or hearing about new ear, nose, and throat techniques to possibly help patients with sleep apnea.
So sleep surgery is one of the 7 or 8 specialties of ear, nose, and throat. And sleep surgery and dealing with sleep disorders it can be very complex. Adults that snore, there's snoring that's not sleep apnea, just annoying snoring that wakes up your bed partner. But then there's sleep apnea, which is usually snoring with pauses in the respiration, pauses in the breathing at night, and then a heavy relief or an arousal where the patient wakes up and gasps for air. That's a dangerous condition. It's dangerous not so much because you're going to choke in your sleep, but dangerous because it does long-term organ damage to the body. Any patient or adult that snores, and child for that matter, should be evaluated by a specialist.
Are there techniques for patients who have, say, obstructive sleep apnea, the term that pulmonologists use? You mentioned it can worsen hypertension, risk for heart disease, stroke goes up. Are there treatments? I mean, people are saying that if they do certain things in the back of your throat, you're able to breathe better.
Yeah, I'm very cautious with offering people throat surgery for sleep apnea. The main things that help with sleep apnea are in patients who are overweight is weight loss, and it does help. It may not cure the problem, but it helps substantially. Younger patients that have enlarged tonsils and that stuff and those types of things can alleviate sleep apnea. The CPAP mask, which is that machine that you wear at night, alleviates the problem. The majority of the time, the problem is compliance with that. Can people keep it on at nights? Can they use it all nights of the week? But there are more minimally invasive office procedures these days and ENT surgeries to help alleviate the severity of sleep apnea, but it has to be the right type of patient.
Let's jump to the ear. Now, the ear, everybody's got ears, and hearing is such an important feature that we all have. And it's interesting, there's some literature that just recently said that patients who have decreased hearing have really a comorbidity of dementia, memory issues. Because if you're not hearing what someone says, you turn off the world in a lot of ways, and your brain turns that part off. So tell us, when should someone go to you or go to an audiologist, and how do they decide? In a sense, a lot of people have hearing problems. They went to rock concerts in the 70s and 80s or even earlier, and they just don't hear that well. How do they know they don't hear that well other than their significant other saying, you're not hearing what we're saying, or the TV was playing so loud? So tell us how we figure that out.
Yeah, it's a great question. I'll bring over my model of the ear just so we can make reference to it. But what you spoke about is so important because it's one of the important senses, hearing, and basically damage to hearing over time is cumulative. People who are exposed to loud, rock concerts or loud noise at work or military service in their younger years will carry the hearing damage with them through their older years. The damage that's done to the nerves in the ear and to the hearing organ, the cochlea, is, again, cumulative. How might you know that you have hearing loss? Well, you have to pay attention to what your loved ones are saying. If they're telling you, hey, you're asking us to repeat yourself, or you're constantly saying, what, you have to pay attention, because that's not normal. People think it is normal to lose your hearing. It is normal. Everyone loses their hearing to some extent. but it shouldn't be to the point where you're asking people to repeat themselves or having trouble hearing people in a crowded environment or like a restaurant or something like that. There are very good options, and people don't want hearing aids, but hearing aids honestly can really help, and they can help with cognitive function too, like you mentioned.
So tell us about cochlear implants. You have this wonderful model. So tell us a little bit about hearing, because hearing is just an amazing sense. And if you think about, we talk a lot about the eye. We have eye doctors who are just so specific in different parts of the eye. Sometimes you don't think about hearing as being in that way. So tell us a little bit of what hearing is, and maybe if you can even try to put together hearing with dizziness, because it's the same nerve.
It's all combined in one area. So in terms of the ear, here you have your outer ear, here you have the ear canal, and you have the eardrum here. And behind the eardrum are all the nerve-type organs that control balance, so that's the center here. And then you have the cochlea, which is a snail-shaped organ here, which controls your hearing. And then you have these yellow nerves here, which go directly to the brain. So that's all related in that regard. To answer your question about a cochlear implant, which is really something particularly helpful for deaf children, or even now being used more and more for deaf adults, is actually an implant that goes behind the ear that's implanted into the bone. And what we do is place a tiny electrode to the cochlea, which is in the snail-shaped organ here, to stimulate it directly. And what that does, it sends a signal to the brain, and it makes the signals that are lost louder, and it can be programmed with very sophisticated equipment these days to actually reprogram the hearing into a more normal type of hearing.
So tell us, and again, this is for me as a curiosity, patients who are deaf and have been deaf for years, is a cochlear implant actually a viable alternative for many of our patients?
Yeah, it could be, absolutely. And it's again, it's a surgery, but it's usually a well-tolerated surgery, and it's an outpatient type surgery where usually someone can go home the same day. In the right candidate, in the right older person, they can get and insurance is paying oftentimes for these days, a single-sided cochlear implant to give back hearing where hearing was lost before. And yes, it can help people who have been deaf for years. It's better to do it in a shorter time span after the deafness or after the severe hearing loss has occurred, because the longer you have, the shorter amount of time that you've been deaf or hard of hearing, the better for recovery. But a cochlear implant can help that.
Interesting. And tell us about dizziness. We're down to our last minute. And vertigo, comparing people who are lightheaded, who are vertiginous, like they're coming off a boat. And patients always want to tell me how they're spinning. Are they spinning the counterclockwise or clockwise? I said, it really doesn't matter. It's all the same thing. It's still part of it's being vertiginous. So tell us, where's the vertigo center?
Here's the balance organ right here, these canals called the semicircular canals. This is a gyroscope. This is the same function in your iPhone that knows if you're pointing east or west. It's like a compass type of thing, whether you're pointing up or down, and you have this on both sides and both ears.
Where are the crystals? Everybody talks about the crystals.
The crystals are located in these semicircular canals. So there's little crystals which float around in these canals, and when you turn your head, all the crystals go to one side or they go to the other. And if your crystals are out of whack or they're in the wrong spot in your ear, you can get what we call, positional vertigo, which, it happens when people get in and out of bed. And we can fix that very readily in the office. Very readily, and people get great relief from it.
And I think that's so amazing, because vertigo is one of the most disabling symptoms that I see, and patients will talk about it, and these maneuvers, as you mentioned, that we could get the crystals to get lined up in a proper way. And I think patients always find it so interesting, when we look in the ear, they think we could see everything. Some people think we can see the other side, and really can't, because the eardrum blocks that off, so we really can't see that much in the inner ear. I want to say thank you. You were so informative, and you know so much, and I'm so impressed, and you're one of my absolutely tremendous guests. So Christopher, thank you so much for being on, and Dr. Lisi, you are marvelous at what you do, and I want to wish you the best.
Thank you, Dr. Perel.
Thank you. We're 3 seconds up.